Okay, go ahead, Ann.
All right. Well, hello, everyone. Welcome to unRemarkable Labs. My name is Ann Wagstaff. I'm a third-year resident at the University of Alabama at Birmingham, and we have a great case for you tonight.
So you got to share your screen so we can see this great case while you scribe. Ann's a rookie.
I'm pulling it up. Okay, Dr. Centaur. So I got the case. Did you want me to present it, or do we have a presenter tonight?
No, you're the presenter.
Okay.
You're the presenter.
Okay, so we have a 60-year-old gentleman who's coming in really somewhat altered.
And since this is unRemarkable Labs, we usually throw the labs out right away.
Yeah, sure. So I will type them here. And so what I'm going to give you first is his BNP.
That'll give us enough to work with.
Yeah, absolutely. Okay. And as I'm typing this out, the most remarkable thing that I want to draw your attention to is his anion gap of 24. So let's start there.
Do we have a glucose?
Yes, I'll type it in.
Okay, Dhruv, be thinking.
All right. So, well, a couple of things are remarkable in addition to that anion gap. Elevated creatinine with a BUN that doesn't look remarkably elevated to me, and hypernatremia. So here I'm trying to think, is this patient dehydrated, or I guess that's the first thing I'd be thinking of. But the other thing that I'd be acid, and he has a gap, he's acidotic. Now I'd be running through a whole bunch of numbers, but
okay. So Dhruv, what's the definition of dehydration? That seems like a simple question, but this actually has confused residents for my entire career.
Oh, right. We need
dehydration versus volume contraction.
Right. Yeah, I think I'd need to refresh my memory on that.
Good. Courtney, help him.
I actually don't think I've heard you talk about this with us, but I think when I think about dehydration, I guess with both of them, a decrease in, I think with dehydration, it's more of a decrease in free water.
That's and if you look at the word, that's exactly what it means.
Mm-hmm.
So
yeah,
that's spot on.
Because you can have volume contraction and your sodium could be not this high. Mm-hmm. So yeah, I would say decrease in free water would be my main differentiator.
Yeah, so that's what causes dehydration. By definition, it's an increase in serum osms. And if the sodium is 155, by definition, you have an increase in serum osms, so you're dehydrated. And what it really means is exactly what Courtney said. We use the term to imply volume contraction, and that's perfectly fine when you're talking to patients or you're talking to people who are not internal medicine number geeks. But volume contraction can occur with dehydration. It doesn't necessarily occur with dehydration. And so we can separate those two things. volume contraction can be overhydrated. So you get volume contracted and drink a lot of water and your sodium goes down. So you can be overhydrated and be volume contracted. Now, why is that important? The reason it's important is because volume is what we're going to try to address. Now we got to figure out why this patient is dehydrated. So that's the number one thing we know. But the second thing we know is what Dhruv said, is that there's an increased anion gap metabolic acidosis by definition, because the anion gap is increased, right? Is that a mixed metabolic picture? Is there an underlying, so for example, if someone's volume contracted, sometimes they'll have an increased anion gap, but have an underlying metabolic alkalosis. Now, how do we figure that out?
Winners. Either winners or
Winners helps us with respiratory compensation.
a respiratory.
I
We don't
usually
have, we
think
don't have a
Oh, a delta gap. You need a delta gap.
delta gap. Okay, so do we know the albumin, Ann?
We do not know the albumin.
Okay, if we assume a normal albumin, let's say the albumin's 11, the gap is 24, so we subtract those two numbers and we get an excess gap of 13. If we add that back to the bicarbonate, it comes out to 27. So this is probably, unless the patient has a very low albumin, a pure anion gap acidosis. Now, that doesn't mean the patient doesn't also have another problem. There could be a respiratory problem, and that's where Winner's equation comes in.
Mhm.
Okay, so we know the patient's dehydrated. Why do people get dehydrated? We don't talk about this a lot. We talk about low sodium all the time, but we rarely talk about high sodium. So Courtney, what do you think of when you see someone come in with a high sodium?
I think the two main processes that would come to mind is either decreased PO intake or excess water loss, if I'm going to put it into two different buckets. So we have a thirst mechanism. So either there's something wrong with that, or it could just be they don't have access to water for some reason, like somebody sitting in a nursing home, or they're altered, and they're not like recognizing the thirst mechanism, and then loss would either be like through the kidneys or gut.
Right.
And I'm sure that those are the kind of main things that come to mind for me.
Yeah. So if it was a young, otherwise healthy person, what disease would we think of?
You know, like diabetes insipidus or
Diabetes insipidus.
Yeah.
So that would be pure renal losses. So you have to consider that, and that's where a urine osm is going to help us. If this patient had a urine osm of 100 to 150, we're probably dealing with diabetes insipidus, and we then would know how to treat the patient. That wouldn't be too hard to treat. Let's say this is chronic kidney disease. How might that lead to this? So the patient has a creatinine of 2.8. We don't have any information on previous creatinine, but when you get to 2.8 and you're 60, I don't know if we have an estimated GFR, but I'm going to guess if someone calculates it for us, it'll be in the 30s or 40s.
Mhm.
Why do those people have a tendency towards dehydration, especially if they can't get water?
Inability to concentrate their urine since their kidneys are
Right. So what happens is
function,
as your renal function gets worse, you start to wash out the countercurrent mechanism.
Mhm.
So you lose the ability to maximally concentrate or maximally dilute, because you need the countercurrent mechanism to do that.
Mhm.
So that's another possibility. Courtney's spot on. What we mostly see is someone who's in a nursing home and gets a little altered and can't get up and get their own water and just doesn't drink. They've lost their thirst, or there's just the altered mental status. But that doesn't explain the anion gap. So we need to go back through what's possible and how we're going to work this up. let's go through Kill You first, and then we'll go back and see what we can find out about the patient
Mhm.
and get the history. But as soon as I see this, I think of the mnemonic that I play with, Kill You. If someone wants to map Goldmark to that, that's fine. Or if you want to do mud piles, that's very last century. So I wouldn't go with mud piles. It's such a 1900s mnemonic. Okay, so what does the K stand for?
So K is kidneys.
Right.
Keto.
Wrong. Correct. Ketoacidosis.
Yes.
Mhm.
Okay, so there's 3 types of ketoacidosis. This could be diabetic ketoacidosis, but they don't give us a glucose. I can't imagine they would give us a diabetic ketoacidosis patient without a glucose, right?
Mhm.
And we all now know, 2 years ago when I would teach this, people did not know how you would get normal glycemic ketoacidosis, but now everybody knows this is a test question.
SGLT2s.
SGLT2s, right? Everybody's got that down. Alcohol ketoacidosis. So if this guy's alcoholic, and there's one thing that makes us think of alcohol. There was a comment in the chat about the BUN being significantly lower proportionately than the creatinine.
Mhm.
And that we see that with people who drink alcohol and don't eat. Now, his altered mental status, we don't know. He might not have been eating for a while, but it just makes us suspicious that there's something going on there also.
Mhm.
And then there's starvation ketosis, and he certainly might have some. It usually doesn't get our gap all the way to 24.
Mhm.
Okay, what does the I stand for?
So the I is ingestions.
Okay, so what are the big 3, and then we have a big 3 and a little 3, and then there are more that I just don't even know.
Ethylene glycol is one of the
Right. If you think of ethylene glycol, what else do you think of? It's not as common as ethylene glycol.
Polyethylene.
So we'll get to that.
Well, not as common. That's just
That's
when you said
that's
propylene
iatrogenic
glycol.
instead of an ingestion.
Yeah. We saw that the other day with somebody who was going through alcohol withdrawals. They had been getting so many IV Ativan pushes that they developed a gap.
All right.
Good. We'll discuss. We'll have you tell us that story here in a second, Courtney. Methanol,
Mhm.
and then over the counter.
Salicylates.
Right, and that's actually really important in pediatrics because little kids will get into that. And remember, salicylates. You generally see a respiratory alkalosis also. So getting a blood gas or at least a VBG is going to help us.
Mhm.
Depends upon whether we think there might be an oxygenation problem. Okay, so those are the big 3. The little 3, one is a pediatric one. Adults could get this, but an iron overdose, I've never, ever, ever seen anybody take too much iron. I've seen people take too little iron, but I've never seen anybody take too much iron. But apparently little kids will get into their mother's iron, infants, 2 or 3. So you need to know that on the list. Isoniazid used to be a big cause before we had directly observed therapy. It causes a lactic acidosis. And then the hot new one that is on the renal boards is also an over-the-counter medicine.
Paracetamol.
Also known in the United States, Dhruv, as
Acetaminophen.
acetaminophen. And it causes, is it 5-oxyproline or something like that?
Yeah, 5-oxyproline, I think.
And there are more and more cases of that being reported. So we just have to keep that in the back of our mind to not miss that. So we when you ask about over-the-counter medicines, just remember that can happen. seems to happen more in people who weigh less. And in, I've seen it unintentional in people who were on a combination of oxycodone and Tylenol, and also taking extra acetaminophen, and only weighed like 80 pounds. Actually saw in a young woman like that one time. Okay. The L.
Like
This is the biggest
lactic
one.
acidosis.
Lactic acidosis. Okay, so I like to think of lactic acidosis in several buckets. Bucket A is also called type A, and that's decreased tissue perfusion. That's dying tissue. So that's what you see in the ICU. Patients on shock, people who are have dying limbs. And there was a very interesting case we discussed last night at Clinical Problem Solvers that some people on this were listening to, and everybody wanted a lactic acid because the patient with an acute abdomen, and he was 77. So everybody was worried about dying gut. And so one of the things that all good residents know is if you have someone in their 70s or older who come in with severe abdominal pain and nothing is obvious, that you get a lactic acid, because the lactic acid level goes up before the anion gap goes up. And that's really well documented in the ER literature. Type B is a big bucket that includes medications and tumors that produce lactic acid. Tumors are usually liquid tumors, but occasionally it'll be a solid tumor. And then there are a bunch of meds. We could name a bunch of them, but there are quite a few meds that can cause a lactic acidosis. Then the next one is the one that Courtney. So tell us about the patient that you saw, Courtney, because that's really worth knowing about.
Yeah, so it used to be a little bit more common when people were put on Ativan drips, which we don't do very much anymore. If we put somebody on a benzo drip, it's usually like Versed, and they're really getting away from that in the ICU. But this gentleman was just having a really hard time with his the CWA score, the score that we use to monitor for alcohol withdrawal. And I think we calculated that he got something like 120 milligrams of Ativan in 24 hours, which is a lot of Ativan. And we just noticed that his gap was going up. And so once he finally was kind of coming out of the withdrawal period and requiring less Ativan, the gap resolved on its own. And he didn't have any other reason for the gap to go up. We didn't actually get a lactic because we attributed that. He was normotensive. Yeah. Everything else, kind of just fit with that. But I think it's worth noting.
Yeah,
you can even get it from pushes.
Yeah, it's definitely important. What happens is that all medicines that you give IV have to be dissolved in something, and Ativan is dissolved in propylene glycol. Propylene glycol, when it accumulates, breaks down to acetoacetate and lactic acid. And there were quite a few articles 10, 15 years ago when people first started discovering this, that as long as you stayed under 7 milligrams per hour of IV Ativan, that you shouldn't run into problems, unless they also have kidney disease, because it's renally cleared. But there's a threshold on how much the kidneys can do it. And then there's the famous Delactic acidosis. So the people at UAB all know Chad Bursky, and he presented a case to me that we actually wrote up in the Journal of American Medical Sciences, I think is the name of it, of Delactic acidosis. And Delactic acidosis may make a comeback because there's some data that suggests that the Roux-en-Y has a little bit better outcomes than the gastric sleeve. That's a big debate that's going on in bariatric surgery. And people who have Roux-en-Y's get bacterial overgrowth. That bacterial overgrowth, the bacteria, if you give them a heavy carbohydrate load, can produce D-lactic acid, which does not show up on your regular lactic acid screen. I think it's worth describing that syndrome in case you ever see it. They act drunk with a normal alcohol level. They feel drunk with a normal alcohol level. They have a mild anion gap. They usually have an anion gap. There's a big article in, if you've ever seen the journal Medicine from Baltimore, where they have big case series. There's a great one on D-lactic acid. And the average anion gap was about 18. So it's a mildly increased anion gap. And the way you can treat it by giving antibiotics to decrease the bacterial load, but the biggest thing is to avoid a carbohydrate load. The lady that we reported had 3 episodes before. Chad was a resident when he made the diagnosis. He's now the fellowship director for GI at UAB. And each time she'd been to a celebration where she ate a lot of pasta, and then the night before she came in to see Chad, she'd had a big pasta meal. And that's a classic history. So that's sort of the lactic acidosis stuff. And then the last is uremia. The U stands for uremia. That's usually, it's phosphates and sulfates, but they usually have a fairly high serum phosphate. This is not, creatinine of 2.8 is probably not enough to cause that. So what could this patient have? We don't know anything about the patient right now. We can't rule out one of the ketoacidoses. This could be someone who drinks too much. We can't rule out an ingestion. So the quick workup for the ingestion. So what are the 2 quick things we're going to do, Dhruv? This is looking for ethylene glycol or methanol, and then looking for salicylates.
Getting a VBG in order to look for.
Right. So that'll help us with which one?
Well, that'll help us with the salicylates.
Right. So, and the VBG is perfectly fine because all we're trying to do is see whether Winner's equation works. Right. What are we going to do if we're thinking about ethylene glycol or methanol?
Get a serum osm, or
right.
A measured serum osm.
We'd expect it to be a fairly large gap if it's serum osms.
Mm-hmm.
So why don't we learn more about the patient now that we've thought through all this stuff? If he's been altered for a while, and if for some reason he's under stress and is sweating a lot, sort of what Courtney was alluding to earlier, that could be why he's dehydrated. And here's the other important point. You know how we worry about with hyponatremia not correcting it too fast? Mm-hmm. There is great new evidence that with hypernatremia, there is no risk of fast correction. There has never been a case of pontine demyelination from correcting hypernatremia. And that's been published recently. And some of the experts, there's a nephrologist who has written a lot about hyponatremia and demyelination, and has testified in many court cases, and he has never seen a case of that. So I would trust him. So but that literature shows that there's no problem with lowering it quickly. So we're going to work on doing that, but let's learn more about the patient.
Yeah, sure. So some of this history is relevant to thinking about this case. So we do know that he is a heavy alcohol user. He's had DTs before. He also has seizure disorder. He has nephrolithiasis and high blood pressure.
Okay, so Dhruv, she just told us something that might be very important.
The seizures.
Right. So work through that.
So I don't know why okay, so my brain's going in two different directions here. One is sort of the known of lithium causing a nephrogenic DI, but then I get to valproate, which is a treatment for seizure disorder and for bipolar disorder, which I get there's the connection between the two, but now I'm trying to figure out how in the world valproate can cause hypernatremia.
I don't think it does, but it does cause hyperammonemic encephalopathy.
Right.
Okay, so Courtney, can you help him on why he's correct to worry about seizures?
I'm trying to know if I'm going on the right thought train, because one thing I think about is after a seizure, I mean, obviously you have the post-ictal state, but it can create a lactic acidosis, so that might explain the gap. So that's where my mind was going initially.
That is exactly where my mind was going. So if I was right, you're right.
Mhm.
I think I was right. This is a classic problem. The patient will come into the ER, will be post-ictal, they'll get numbers like this, then they'll get a blood gas, and the blood gas is totally normal.
Mhm.
Or they'll get a point of care blood gas, and it shows a marked acidosis, and then they get a BMP, and by the time they get the BMP, it's perfectly normal. And that means they caught the post-ictal state, because seizure, when we remember what we're saying about lactic acidosis, it's anaerobic metabolism, and seizures cause anaerobic metabolism.
Mhm.
If he just had a seizure, or if he's in status, that's going to be a problem.
Mhm.
We guessed that he was an alcoholic. Excuse me, he was an alcohol abuser, because I think alcoholic is no longer. Am I going to get canceled for saying that? I don't
Not
think
this
so.
time.
That was pretty sarcastic, wasn't it? Somebody in the chat canceled me. So that might explain that 19 to 2.8, that he really is not eating well, which makes us worry about an alcoholic ketoacidosis and a starvation ketosis, or the combination of the two. So we have two more things. We have two things that are in our differential. Could he have drunk the wrong stuff? It's amazing that people who drink alcohol to excess are more likely to also drink stuff like ethylene glycol. They're really good about not drinking methanol, because they heard that'll make you blind. We did have a case in Huntsville once where a guy had drunk moonshine, and they cut the moonshine with ethylene glycol to make it taste better, because ethylene glycol has a fairly sweet taste, apparently. I've never done that. Okay, so what else do we know about this guy?
Yeah, so let's go ahead and talk about his medicines too. Let's go ahead and throw that in. So he takes aspirin, lisinopril, levetiracetam, and valproic acid.
So you got the valproic acid. That could explain the altered mental status.
Mhm.
So I would always get, if somebody comes with altered mental status and is on valproic acid, I'd always get an ammonia level, because I have seen hyperammonemic encephalopathy from valproic acid.
Mhm.
The aspirin is concerning, right?
Pulse light.
We didn't ask about acetaminophen, but we don't really know, right? This is what we know he's supposed to be taking.
Mhm.
Okay. We wanted either an ABG or a VBG. Do we have one of those?
We do not, but just to sort of give you another piece of information, we can go ahead and look at the measured osmolality, if that would.
Okay, let's look at the Osms.
Yeah, so the measured osmolality is 340.
Okay, so what are the estimated Osms? And it's really hard to do this without the glucose.
It is. We do have that information. I'm happy to give it to you.
The estimated ones.
The
Let's go over how you do that.
Yeah.
So we got 340 is measured osms. Okay. Dhruv, do you remember the formula for estimating the osms?
It is, so it's sodium plus BUN over, God, I'm trying to remember the molar mass of BUN or
Okay.
urea. And
So
then and plus glucose over, I think, 18.
Right, glucose over 18, urea nitrogen over 2.8.
Over 2.8.
Yeah, and that's just a nerdy equation. In the real world, you look it up on MD Calc. But you also need the alcohol level because this guy has a history of alcohol abuse.
Yeah.
And alcohol will give you an osm gap, but it's 2 times sodium. So 2 times sodium is 310. His BUN is 19, so that's going to be about 7. So we're up to 317. His glucose. So what number did they give for the estimated osms?
324.
324. So that means that he had a slightly elevated glucose. So the gap is 16. Are you impressed?
Not really.
Courtney's not impressed.
I'm trying to remember. I think the cutoff is 20, but it could be 10. I'm torn. I'm just gonna be honest there. I'd have to look it up, but it's like for some reason 10 is in my mind, so it's I'm just gonna say that.
And we don't know if they measured an alcohol level, right?
We actually do, and it was negative.
It was negative. Okay, so if the alcohol level is negative, which might be why he might have had a seizure. If you're drinking and you have a history of DTs, and then you come in with altered mental status, that's certainly a possibility. This is such an interesting question. Are we worried about ethylene glycol in this guy? If we're worried, what are we going to do? So I'm going to pick on you, Courtney, since you're in the ICU.
And I'm trying to remember if this is one that you would be able to dialyze off, or if you give starts with an F, but I'm not remembering off the top of my head.
Right.
Nope, I'm gonna start with an F. I think you give that. Famipizole.
It's famipizole.
Yeah, famipizole.
Yeah, famipizole, and famipizole. I actually looked it up. It cost about $500 because I give this talk all the time. It used to be, when it first came out, it was like $3,000, but it's actually cheaper than a dialysis. You can dialyze it. Let's say your hospital doesn't have famipizole, and you're not going to be able to get the patient dialyzed for a couple days. What else can you do?
IV vodka.
Well, you can either give IV or oral. There was a great case report of someone in the Outback that all they could do was give them whiskey because they didn't have any IV alcohol. What level of alcohol do you want them to be? So what you're doing is competitive inhibition, because there's nothing wrong with ethylene glycol or methanol. It's their metabolites that are the problem.
I think get them to 80 mgs per DL of alcohol.
That's probably good enough. I've always taught 100. Okay. And if someone in the chat knows whether there's an exact number on this, what you want to do is you want to get them pleasantly drunk if you can't measure alcohol levels. And that works. And the case in the Outback, that's how they controlled it. Do you want to do that for this patient with the osm gap of 16? The ethylene glycols that I've seen, the gap's been in the 40s and 50s or higher. And I'm just not sure that I would get but so excited. But I've seen nephrologists get excited by gaps of this of osm gaps of this size in the past, and go ahead and give famipizole.
Do we have a lactic on him?
What?
Just to make sure that's ruled out? Like,
Yeah, do we have a
is
lactic?
this gap explained by the osm gap?
Yeah, that's a great point, Courtney. We actually do, and it might kind of broaden this differential too in what's going on with the patient. So his lactic acidosis, his lactic acid was 13.9.
Yeesh. That's high.
Okay.
So, Courtney, you're an experienced resident. That was a great question, the logical question that an experienced resident has. Now, what are you thinking? So, what was your reasoning behind that? Share that with everybody. Why you said let's check a lactic acid, and now is that going to impact what you do?
Well, I guess there's always multiple reasons why somebody could have an elevated gap, and I'd want to make sure that I rule out what's easy to rule out, and getting a lactic is pretty easy. Now I'd have to think through like what's going to kill a patient is kind of where I'm going with this, and a lactic of 13 is definitely something that I would be worried about. I'd like to see a set of vitals on him for one to kind of rule out potential like hypoperfusion situations. For I guess that's where I would start with this.
Mm-hmm.
In the meantime, are you giving this guy fluids?
Yes.
And what are you going to give him?
Probably at least 30 cc's per kg. It'd be nice to have a set of vitals. I probably would have had that first. But...
Okay. So I guess the question here is whether we want to give this guy pure fluids, isotonic fluids, or hypotonic fluids, because his sodium is so high.
Yeah.
So this is the tricky part. We know he's dehydrated. Now we got to figure out if he's volume contracted. If he's volume contracted, we got to treat the volume first and then worry about the dehydration. If he's not volume contracted, and that's really hard to tell. Now, if he's hypotensive and tachycardic, then I'm going to start running in Ringer's lactate. And I'm going to run it faster than that. I'm going to run it really pretty fast. But if he's not, if he's not tachycardic, I expect he's going to be tachycardic because he's a mess. But the instinct to worry about the vital signs is beautiful. So Norma asked D5 and W. Now I probably wouldn't give D5 and W. I'd probably give D5 half normal to start out with, because I'm suspecting that there's at least some volume contraction. But what do we find out from the vitals, Ann?
Yeah, so the vitals overall, you're right. The patient is tachycardic. It's normal. It sounds regular. The heart rate's 125, but the blood pressure is 134/100. And the rest of his vitals, his temperature is 37 degrees Celsius. His pulse ox is normal, and his respiratory rate is 17.
So if I were skilled, and fortunately, almost all the residents I work with are skilled, I would check the IVC and see if there's IVC collapse as a better way to estimate whether or not the patient's volume contracted. I'm concerned about the tachycardia, but so many things can cause tachycardia because he's an unstable patient, right?
It's sinus tach. It's the most sinister of rhythms. I guess the other thing too that I would put in, just going back to the discussion about giving him D5 half normal, is would we add thiamine onto that before giving him anything?
Oh, absolutely. No, so you have to do two things before you give D5. You have to give thiamine. How much thiamine are you going to give?
I think it's 100 mgs is the whatever the high dose is.
So that probably is what you were taught, and that's not what we're teaching in 2020. And Robert Weber has it spot on in the chat.
Oh, it's 500 TID.
Yeah. That's to make sure that you've repleted. You do that for 2 or 3 days, and then you cut back a little bit.
Mhm.
What else should you
We have
check?
a power plan that's that easy.
What?
We have a power plan that makes that easy with
Good.
thiamine replacement for altered mental status.
What else? What else should you check in this guy before you give him glucose? It's one of my. I'll give you a clue. It's one of my favorite pen questions. Say it.
Phosphorus,
Phosphate.
like your
Yeah.
phosphorus.
So if he's not been eating, he could easily develop hypophosphatemia. So
A refeed, yeah.
So you check the phosphate first. If it's okay, you can go ahead and give it, but you got to check it again the next day because you could quickly induce hypophosphatemia. And when I was up in Huntsville about 15 years ago, we had an M&M of a patient who died, who actually came in with a phosphate of 0.7. It had been ordered stat, but it wasn't done stat. And about the time they were calling back the level, the guy was in VFib.
Yeesh.
So it can absolutely kill you.
Mhm.
So Dhruv, you're the intern. Write the orders now. You got to you want to give him some IVs, and do you want to give him any medications? What do you want to do for this guy?
So the other thing is that I'm wondering if he is also seizing. So he's supposed to be on Capra. He's supposed to be on valproate. I'd want to just examine him, see if he is actually seizing, and if that's the case, give him a dose of Ativan.
Okay. Is it worthwhile to check blood levels of those of the
I mean,
valproate?
we could, but I'd be more inclined to just start them at the doses that he's supposed to be on and just see if he'll get back to something resembling a normal.
And what do you think is the chance? So we haven't had anything about seizure activity reported to us. What's the chance that he's seizing and you can't tell from physical exam?
Well, in that case, you'd want to do an EEG to see if he is in something like a subclinical status, but I don't think that's very likely with how this guy is.
Courtney, what's your experience with seizures?
I guess to answer the question at the levels, you might as well just grab them so that you have them, because sometimes those take a little while to come back, and it gives you information if he's taking his anti-epileptics. Typically, people who are having seizures, it should be relatively obvious. I mean, if they're in status, that might be sometimes a little bit more difficult. In order to get an EEG, that usually takes a little while. Somebody with a history of alcohol use, there's certain things with the exam that can kind of tell you if they're in that like part where it's like DTs where you start worrying about seizures. But I guess altered mental status can mean a lot of things. So a physical exam would probably be where I'd go next before I'd push Ativan, because once I push Ativan, I might not get a good physical exam.
Yeah. Okay. Do we have a physical exam, Ann?
We do. So he is, somewhat responsive. He's lethargic, but he's not following commands. His pupils are normal, and they are reacting to light. He's moving all of its extremities symmetrically and is withdrawing from painful stimuli throughout. He does have a Glasgow coma score, though, of 7 out of 15. And so they actually intubated him for airway protection for that reason.
Okay, so do we decide our orders yet, Dhruv?
So
do you want to give him famipizole?
I'd be less inclined. I'd think, yeah, I'm honestly not sure. I think I just want to start fluids on him first, see how that goes, and I wonder what delaying the decision about either fomepizole or competitive alcohol inhibition would do.
Courtney,
GCS at
you're
7.
supervising him. You got to give him feedback.
I think we're in kind of a tough place because he's got multiple things going on that could be driving his mental status, and we still don't have all the information. But I think fluids are a good option for him. It's hard because I don't have a baseline blood pressure to know if this is normal for him. I mean, he could have a blood pressure, like this could be a relative hypotension. With a lactic acidosis that high, I feel like something else is going on. It's not like this is somebody who's presenting with like septic shock. But so I guess the reason why I'm talking about this is, do I give him fluids at a rate and go towards correcting his hypernatremia, like D5 half normal saline like we talked about before, or start bolusing him because he's got this lactic acidosis? I kind of want to give him a bolus and see what happens to his lactic acidosis and go from there. I think giving him thiamine is definitely a good choice, and then get some more information. So that's probably where I would start.
Great.
And I think he'd be somebody that, I have the intubation going in my favor in the sense of I can at least not be quite as worried about withdrawal seizures, with something like propofol, because that would kind of ward off the DTs.
Right. We don't want to add the extra propylene glycol at this point.
Right. Yeah.
Okay, so I'm gonna give y'all an A. I really like your game plan. Let's see. Let Ann tell us the rest of the story, and then we can sort of do a post-mortem, so to speak.
Yeah. So I think one key lab finding, y'all are doing a great job thinking through all of these things, and a lot of these things are relevant to this case. A couple kind of clues that I haven't given you yet is that he had an elevated CK of 1,016. And then when we looked at his urine, he had some red blood cells, some white blood cells, but he had calcium oxalate crystals on that urinalysis.
Oh no.
Does that
He
change
did
my
get into
theory?
ethylene glycol, didn't he? How did I miss this? Why didn't I ask for a UA?
So how specific is the calcium oxalate crystals?
Although it's not necessarily that specific because you can still get oxalate crystals even without an ethylene glycol.
So you want to give him fomepizole or alcohol?
I mean, at this point, given his history and his clinical picture, I probably would.
Okay. Does your upper level agree with you? That's you, Courtney.
Thank you. I'd have to re-review what I feel like. Calcium oxalate crystals are aren't those pretty common? He has a history of nephrolithiasis, or
True.
Yeah.
So I'm thinking I'd be treating this guy like somebody with rhabdo at this point.
So there's a very
But this
important...
is where I might have to review what's found in the UA.
Yeah. There's a really important point in the chat. Kushal, could you unmute yourself and talk about the thiamine deficiency in lactic acid? Tell everybody what you know about that.
Hey, everyone. I'm not sure about the exact mechanism of the thiamine deficiency causing lactic acidosis, but I think it's related to the glycolysis cycle. It gets sidetracked, and instead of so pyruvate converts to lactate, and I think it accumulates. I think I'm not sure of the exact mechanism.
Yeah. So that's something we always forget. I'm so glad because I keep forgetting it. And so one of these days I'm going to remember it. So I really appreciate the fact that you brought it up in the chat. When we talked about thiamine deficiency, we always ought to remember, we always think of Wernicke's and stuff like that, but it is a cause of lactic acidosis.
And I think Gerline actually put the explanation in the chat that it's a cofactor of pyruvate dehydrogenase, which converts pyruvate to acetyl-CoA. So if you don't have that, pyruvate gets shunted to lactate.
Yeah. So that's definitely a cause. Okay, so we're going to give this guy a dose of famotidine. We're going to give him volume. We're going to recheck his numbers, and then we're going to send off an ethylene glycol level, which is going to take forever. Now we should have we had an alcohol level. So when I actually read this case ahead of time because I got this case out of the literature, and I was not very impressed with an Osm gap of 16. But maybe I'm just too skeptical. So back to the denouement.
Yeah. So the people taking care of this patient did, they were worried about ethylene glycol in this patient, and so they actually they did not have access to famotidine. So they actually started this gentleman on an ethanol drip while they waited for his ethylene glycol level to come back. And so they sent an extensive tox screen that was actually negative for ethylene glycol. It was negative also for acetaminophen and salicylates. It was just negative across the board. So eventually, Dr. Centaur, do you want me to just take it home, or do you want me to?
Yeah, take it home.
Yeah. So eventually, they were able to, this patient woke up, he was able to be extubated, and, they were scratching their heads about what all of this could be. And ultimately, they determined that really probably the reason for his anion gap and his osmolar gap was his lactic acidosis. And they, I think the important learning point here is that you have to think about ethylene glycol when you see an elevated anion gap, an elevated osmolar gap, and calcium oxalate crystals, but other things can explain all of those lab findings. So, that's the perfect triad for ethylene glycol, and you need to treat as such. But if you have an elevated osmolar gap at the time that you collect that ethylene glycol level, it should be positive. And if it's negative, then you can feel pretty good about saying this isn't ethylene glycol.
Mm-hmm.
So rather than this being a bit of a zebra, this was absolutely a plain old brown horse.
Mm-hmm.
This was just a classic guy who's drinking. If I remember right, didn't they measure a valproic acid level?
It did, and it was actually low. It was subtherapeutic.
Yeah. So
and I would imagine his Keppra level would probably be low too.
Yeah. So Dhruv, what are your big take homes from this case?
That number one, go through when you go through a BMP, try to figure out a way to go through it as methodically as you possibly can. I guess it's when I went through it, I was trying to look for all the values that were out of whack to me, and I didn't necessarily have a good way to figure out, okay, where is the stuff? What is the stuff that'll allow me to get through to actually make sense of this BMP? Mm-hmm. And I think the second thing is that a triad does not necessarily an ingestion make. Even though you have an increased osmolar gap, even though you have the anion gap, even though you have the oxalate crystals, even though you have an alcohol history, doesn't necessarily mean that the guy drank antifreeze. given his seizure disorder history and given his nephrolithiasis, it was more on the order of a Hickam horse, multiple things that are common enough that cause this presentation instead of the Occam zebra, the one thing that would be rare but explain everything.
Courtney, what are your big take home?
Need to review urine microscopy. And then I really liked the take home point with the thiamine deficiency, because I definitely, it's something I always go to for, encephalopathy, and especially somebody with a history where that's a strong possibility. So I'm pretty good about making sure to grab that order and then empirically replete at the high dose. But to associate that with a lactic acidosis was a good review for me.
Mm-hmm.
Great. And Anne, what do you think our take-home points should be?
Yeah, I think that those are some great take-home points. I think really an important thing is when you see a pattern to not have premature closure, but to continue to explore the differential and to revisit it. And when you have something like a negative tox screen, then you need to go explaining those labs through some other mechanism. I also think, though, that if you have a life-threatening potential diagnosis like ethylene glycol, it's appropriate to go ahead and treat as such and not wait for confirmation as they did in this case.
So we didn't, the last thing I just want to mention, we didn't mention that CK, but that CK is very consistent with postictal.
Mm-hmm.
And it's probably just another clue that it was postictal. I'll be glad over the next day or two to post the case where we got the case from, because when I read the case, I was looking for something different to present. I thought that it was a case that had a lot of twists and turns, and I hope everybody in the chat learned a lot, and because I learned a lot from reading this one. So thanks to everyone for joining us today, and thanks to our discussants for doing a great job.